Our next paper is going to be prospective randomized trial comparing laparoendoscopic single-site, that's LESS, less surgery, with traditional multiple-port laparoscopic surgery for adjustable gastric band, being presented by Dr. Afthinos.
Okay. Thanks very much. I want to thank the session chairs and sages for allowing us to present our data today. We're discussing a randomized trial comparing less surgery versus multi-port for adjustable gastric banding. These are our disclosures. Recently, Dr. Teixeira and his group demonstrated the safety, feasibility, and a similar operative time for less approach for gastric banding. And also, Dr. Nguyen was able to demonstrate the safety of the technique as well. Dr. Saber was able to demonstrate a decreased post-operative pain, and Dr. Rahman was able to take it a step further and demonstrate a faster return to work and decreased narcotic consumption. So we reviewed our retrospective data initially, 100 multi-port bands and 108 less bands, and we noted a statistically significant decrease in operative time, length of stay, narcotic consumption, and pain post-operatively. We therefore sought to determine whether less gastric banding has a comparable safety and efficacy profile compared to the standard multi-port technique. We therefore designed our study to be prospective, single-blinded, randomized controlled trial, and based on our findings from a retrospective review, we powered it for superiority. Our primary outcomes included operative time, complications, conversion to multi-port or open procedure, and secondary outcomes were pain, narcotic consumption, length of stay. We did a cosmetic assessment, excess body weight loss, and quality of life scores. Patients who had chosen to have a band placed as their bariatric procedure of choice, whose age was between 18 and 65, and whose BMI was between 35 and 45 were included. And patients who were excluded had hepatomegaly, prior open abdominal surgery, and evidence of hiatal hernia, and other reasons not to have band. Randomization was performed in the holding area just before the OR with an online virtual coin flip tool. Our standard multi-port technique involves the placement of 5 trocars, a 15, a 12, and 3 5s arranged as seen here, while the LESS approach uses a periumbilical multi-port device. And the operation is the same for both. We do a blunt dissection of the angle of His, we use the pars flaccida technique, and we use gastric plicating sutures about 2 to 3. Regardless of the procedure, the patients all received standard multi-port dressings as shown here. Of the 66 patients who underwent gastric banding during this time, 38 met the criteria while 9 refused. The remaining 29 were then randomized to 14 and for a single incision and 15 for multiple. The patients who refused, 56% actually thought that they would have increased pain after multi-port procedure. 22% felt that LESS offered a better cosmetic outcome, and 11% thought that LESS was experimental. Of the patients, there was no statistical significant difference between age, BMI, or distribution of comorbidities between the two groups. There tended to be more Caucasians in the LESS group and more African Americans in the multi-port group. We found a statistically significant longer operative time of 18 minutes more in the LESS group. Each group had 1 complication apiece, and there were no mortalities and no conversion to a multi-port or open procedure. These are both port-related, and they were several months after the surgery. We did not demonstrate a statistical significance between hydromorphone dose post-operatively, length of stay, or duration of their PCA. Post-operative pain charted at 0, 1, 12, and 24 hours post-operatively were also not statistically significantly different. And the excess body weight loss post-op over the course of a year of follow-up was also similar, was not different. We performed a cosmetic assessment. By that, we showed the patients 2 photos, one a photo of a patient's 6-month post-op from a LESS procedure and one from multi-port. And we asked them retrospectively before we took their dressings off what would they prefer. And 79% of them preferred the LESS approach, while the other 21 had no preference at all. We were also able to demonstrate a statistically significant increase in the physical function scores of the LESS group on their quality of life index, SF36. So in conclusion, we were able, it appears that less gastric banding is comparable to standard laparoscopic gastric banding in terms of the safety profile. It took slightly longer, about 18 minutes, and the patients in the LESS group demonstrated an increase in the physical function scores of SF36. No differences in pain or narcotic consumption. In terms of limitations, the study was underpowered to demonstrate statistically significant differences with secondary outcomes. However, we've already gone ahead to extend our study to try and determine these differences. And the design may have impacted the length of stay, as we deliberately used the PCA to accurately measure narcotic consumption and pain scores, and that it may have impacted length of stay. Thank you for your attention.
We'll take some questions from the floor. First off, this study was performed after your center had already performed how many LESS gastric bands?
About 108.
And how do you think these results would translate to somebody who may be undertaking the LESS approach to gastric banding?
Well, part of it is that, again, as we saw, we used this is for a select group of patients, and we carefully picked them so that these would be patients who this would be more straightforward. And I guess that's the whole thrust of this, is that this is going to be for a select group of people. And I think for people who have experience, and it's going to take, exposure and practice if you're going to undertake this. Start doing this as and offer it as a way of approaching banding for your patients.
Okay.
Yes, sir.
Bill Richards from Mobile. Listen, I really like this study. This is a great way to do scientific surgical research, because you came into it on your retrospective review convinced that the LESS approach was going to be faster, less pain, out of the hospital, everything else, okay? So what do you tell your LESS patients now for those people that want to have the LESS procedure? And what do you think that 18 minutes in the life of a busy surgeon for each case is going to mean?
Thank you. I think for the second part, 18 minutes probably is clinically insignificant, and I think that in terms of running a practice and so on, it would add up if you do 7 of these in a day. But we're hoping that over time that actually will continue to get decreased. And for the first part, I think that we haven't shown any difference. We haven't shown any worse pain syndromes or increased complications. I think it's still viable to offer this to patients and tell them that those are going to be the same, but they do have the added subjective benefit of the improved cosmesis, at least by what we saw.
One more question.
Sure.
Pandey Enamula from Lansing. Regarding the cosmesis, at what point did you ask the patient? Is it 1 month after surgery or 1 year after the surgery?
No, I'm sorry. That was immediately post-op, before they were unblinded to the procedure that they had. So the day after, the dressings were still on. They still didn't know which one, and we showed them these and asked them, what would you prefer, in a retrospective manner.
So obviously in the immediate post-op period, scars, it is very obvious. Any simple incision you make, it is very obvious. But at 1 year, some of these tiny incisions, they're invisible.
I know.
Thank you very much.
Thank you.